I think first, to understand what a hiatal hernia is, it's helpful to know what the anatomy should be. So the esophagus is a long muscular tube that empties into your stomach. Where those two meet in an ideal situation should correspond to where the diaphragm is. The diaphragm is the muscle that separates your chest from your abdomen. It helps you breathe. In a hiatal hernia, what's happened is the stomach has snuck up above the diaphragm some. There can be varying degrees of this. It can be just a little bit, like in a sliding hiatal hernia, or it can be a large majority of the stomach is up there, like in a paraesophageal hernia, which is just a special type of hiatal hernia. You can even have other organs that have slipped up there, such as your spleen. In a hiatal hernia repair, our goal is to pull that stomach back down below the diaphragm where it belongs. The next step is in recognizing that that diaphragm hole around the esophagus where that stomach was is generally too big. So what we do is sew that closed so that it's the right size. Sometimes we may choose to reinforce that area with a mesh that's often a resorbable mesh, but we make that decision on an individual basis and after discussion with each patient. After that's done, typically we follow this with an anti-reflux procedure. This is often a wrap, or the technical term is a fundoplication, which involves taking your stomach and wrapping it around your esophagus to kind of recreate the valve that should be there. This can be done in several ways. Some people approach these through the chest. That's generally a more painful, longer recovery. Some people approach them in an open fashion, which is a big incision that would be on your abdomen. That also tends to have a longer recovery. Our kind of gold standard, if you will, is to approach these in a minimally invasive fashion. So that means small incisions on your abdomen, and this can be done either laparoscopic or robotic. And the benefit of that is getting you out of the hospital faster. To determine if you're a candidate for surgery, it's going to involve some preoperative workup just to make sure that it's the right thing for you and that we're offering you the right surgery. This often involves a collaborative approach with our GI doctors. I'd say the most typical workup would be undergoing an upper endoscopy, also called an EGD. So that's a long tube with a camera going down and looking at your esophagus and your stomach and the first part of your small bowel. We also typically like to get a swallow study of some sort. That's a rather easy study where you swallow a material and we take x-rays. That's done through the radiology department. And then it's also pretty important to have some kind of motility study. So that's looking at the function of your esophagus. And that's going to help us determine what type of repair we can offer you. After surgery, you can expect that you will be admitted to the hospital. Typically, we keep patients for 1 day. The following day, as long as your labs and vitals look okay, your pain is controlled with the pain regimen that we have you on, you're able to walk around, and importantly, that you're able to get enough liquids down, we send you home. You can expect that you will have some swelling where we were operating. That's totally normal, and because of that, it can be a little difficult to swallow just in that post-operative period while that swelling's going down. Because of that, we put you on a special diet. That means a liquid diet for 1 week. Following that, you'll be on soft pureed type foods for about 3 weeks. We do have a nutritionist meet with you while you're still in the hospital just to review diet and answer any questions that you have about that.